Tarun Mittal is from Delhi only, and he'll be presenting a redo Hiatal Hernia surgery. He is a laparoscopic, laser, bariatric and robotic surgeon in Sir Ganga Ram Hospital, New Delhi.
From one Tarun to another Tarun, I thank Dr. Mishra sir and Dr. Bhalla sir for giving me this talk. I bring greeting from Sir Ganga Ram Hospital, and so as we know, a lot of laparoscopic fundoplication and hiatus surgeries are going on. So over a period of time, because it is now minimally invasive, we will see more patients of revisional surgeries also, redo hiatus hernia or redo fundoplications also. And there is a lot of radiographic recurrence to the tune of 50% when you follow up these patients. But what is important is what is the symptoms which patients have. If patient does not have symptoms, we do not have to operate these patients. It is only when we are not able to provide them symptom control or undesirable symptoms occur, then it is called a failure and you might require a revisional surgery. In many of these symptoms are also there, you might not have to do surgery, you might treat them conservatively. Only 3 to 6% of the patients who complain of severe symptoms or some complication will require revisional surgery. So all the patients which you see in OPD has some hiatus hernia post fundoplication, you do not have to operate all these patients. It chal nahi raha hai. Next, so there is a lot of factors which cause this recurrence. One is a patient factor, other is a tension, and other is a technical factors. So most important is the tension. One can be either an axial tension, which is vertical tension parallel to the esophagus and causes cephalad migration of the wrap. Normally physiologically also there is approximately 2.5 centimeter movements of the G junction upwards. Because of the elastic recoil of esophageal membrane, which act as a contracting force, it is considered normal. But if there is lot of fibrosis, if it's a very large hiatus hernia, or if there's a stricture is there, or Barrett's esophagus is there, it means it is an old disease. Then you might have a shortened esophagus because of the fibrosis, repeated esophagitis and fibrosis. So that we have to know, and we would have to correct that. The other thing is a radial tension, which is between the two pillars of the crura. Diaphragm is in constant dynamic nature, this constant movement is there, and because of it there can be breakdown of the crural repair with resultant failure. So this is manifested by if we are having, when we try to approximate the right and left crura, if we are having difficulty, then we might have to use a mesh, or we might have to do something extra, otherwise there can be a failure. The other thing which is very important is post-operatively, when you operate these patients first time, there should be strict nausea control, or give them some injectable when a patient is admitted, because if they have retching, this whole of the wrap can migrate. They should avoid heavy lifting, strenuous exercise, contrary to other laparoscopic procedures like lap cholecystectomy hernia. In this, they should avoid this for at least 4 weeks, because increased abdominal pressure can push the wrap upwards. The opioids which causes nausea should be avoided, and generally nasogastric tubes are not required, and you should always try to control these nausea, vomiting pre-operatively and preemptively only to reduce the tension post-operatively. The other factor which is very important is BMI, which is controllable. It's a patient factor. If patient is very obese, then you might have to counsel these patients, and a bariatric surgery might be required in these patients if it is very obese, instead of just doing a hiatus hernia repair in these patients. So there are other technical factors. Other can be a misplaced wrap. You might not have done the complete hiatus dissection. You might have a misidentification of G junction. You might have not divided the short gastric, so there would be tight wrap might happen. Surgeon training and experience is very important factor. If you have got trained with a surgeon who had been doing routinely, and if you are doing this surgery initial phase of your career without much training, you might have complications. Then there can be tightness of the fundus fundoplication, tightness of the crural closure, all steps when you are doing it first time, you should assess these things and then only operate. They can be loose sutures, improperly tied knots, poorly tissue bites. All these can result in no fundoplication. The fundoplication might go and patient might have recurrence of the GERD symptoms. So all these can be the factor for recurrence. So what are the most common complaints? The most common complaints are same as it was as the first surgery, except the dysphagia might increase in these patients. They can have heartburn, regurgitation, chest discomfort. So all these patients, these things can be there in normal post-operative course also of routine fundoplication. Like some dysphagia will always be there, and for 3 weeks we advise them a specific diet, and after 3 weeks they should resume their normal diet. Anyhow, after that also they should eat small frequent meals, chew the meal well. So this all things should be told to these patients preoperatively only. So if you have not told these things preoperatively, then patient will be having a lot of anxiety and patient will not be satisfied with this surgery. So we should wait for at least 3 months for this symptom to resolve, and then only one should try to operate these patients until as they complete dysphagia. And initially they should be managed conservatively, and if they do not improve, then one might require the surgery. So there are various investigations which can be done in these patients, and one of the first earliest investigation which used to be done is a barium esophagogram, in which you take up AP view and then a lateral view also to assess the GE junction fundoplication. So on this there is the classification is there based on the barium esophagogram, in which types of failure have been described, and you all should know this. One is a type 1A failure, in which both the GE junction and fundoplication and herniated above the hiatus. This is the most common, and it is because of both the increased radial and axial tension. The type 1B is a slip fundoplication, in which the GE junction is above the hiatus and the fundoplication is below the hiatus, misjudging the location of the GE junction, placing the wrap low around the cardia instead of the fundus. This is because of increased axial tension due to unrecognized short esophagus. Second is a type 2 failure, in which the greater curvature of the stomach is herniated above the GE junction, but the GE junction and wrap is below the hiatus. This is type 2 failure. And type 3 is if you use a mid body of the stomach to construct the wrap, in that patient will have a persistent dysphagia. So the next investigation is apogea endoscopy, in which you can see all the types of failures of fundoplication by an expert anesthetist. You can see Barrett's esophagus. You can see if there is erosion of the mesh or foreign body is there or not there. This all can be assessed by the apogea endoscopy. Along with if they have dyspeptic symptoms, you can also assess the H. pylori infection or gastritis is there or not there. So these are basic findings of all the complications which can happen, and the expert endoscopist can have a guide when he sees those findings, that what type of a failure is this patient has. The most important investigation after the endoscopy is a manometry. It is must in all the patients. You have to assess the esophageal motility, if patient has motility or not there, and what is the GE junction pressure is there. Sometimes there can be pseudoecclesia post fundoplication. If there is absence of motility and you have done a nascent fundoplication in this patient, you might have to undo and do a partial fundoplication. And in this, they can also assess the fundoplication configuration. What type of failure is this? They have distinct findings are there based on the lower esophageal pressure, integrated relaxation pressure, in which we diagnose the pseudoecclesia. What is the high pressure zone? What is the distal contractile integrity and esophageal motility? Most important factor for us is esophageal motility and the lower esophageal pressure and integrated relaxation pressure. So sometime if patient is having lot of bloating, they might undergo a gastric motility study, especially in revisional surgery, and you might have to put a Botox or sometime do a pyloromyotomy or a pyloroplasty along with the fundoplication if there is a motility disorder, specifically in diabetic patients. So based on the physiological state, severity of symptoms and response to conservative therapy, we might have to operate these patients because of refractory refractory reflux or intractable dysphagia which is not getting better, and many of these patients can have respiratory complication or atypical symptoms also, and that also will be corrected after the surgery. So what type of a procedure we do will be depend on what is the reason for the first failure, what is the esophageal length, and what is the peristaltic reserve of this patient. Whether if it's normal motility, you might do a complete fundoplication, otherwise you should do a toupee or a door fundoplication based on the what is the finding intraoperatively. Most of the time now, initially it used to be open, transabdominal or a transthoracic approach. Now thoracoscopic approach, but the most commonly performed approach is a laparoscopic approach with low conversion to around 7%, and that is almost a gold standard procedure for these patients. So there are various steps of procedure: anesthesia, insufflation we do by varies, then meticulous adhesions, Hiatal dissection, and then takedown of the previous fundoplication is very important. You should make it a normal anatomy and then do whatever you want to do. Otherwise, you can confuse and you might do again a wrong procedure on these patients. I will be just be showing a video, two videos. This is a video of a patient who underwent a fundoplication at some other center, and he was post-operatively, he had a vomiting, retching. Then patient developed a recurrence hiatal hernia, and the surgeon was outside the country, so the patient came to us. So in this you would see whole of the wrap has migrated into the thorax, and there were a lot of adhesions were there, lot of momentum adhesions, and the wrap adhesions were there. Slowly by gentle pulling technique we could reduce this stomach, and then we start the dissection of the crura. Here we are dissecting the left crura, trying to dissect it from all the adhesions which are there, and trying to mobilize simultaneously the wrap and the esophagus. After this left crura has been mobilized, then we are doing the right crural mobilization. We generally use LigaSure because it's a very good instrument. It helps in dissection also, and it's a bipolar type of a device, so it's very good. So after we have gone around, we take a cotton tape and try to retract all of this. Here you would see we have injured, because there were a lot of adhesions between the wrap and the pleura, so the pleura has opened. If generally it's a small tear, we do not have to do anything, but here it was a lot of adhesions were there, and here you would see this is the fundoplication, which plicated suture which have been taken and which we are undoing with the help of a scissor. But should not use a energy source for doing this. It should be a sharp dissection should be there. Here we are doing all the posterior dissection, and you would see whole of the right part of the lip of the fundus which fundoplication has been done, has been lot of adhesion is there. Here now we are going into, this is the left side of the wrap is there. Here also there were a lot of adhesions were there. Because it was a large tear, we placed a chest tube and removed it on 3rd, 4th day. If it is not large, then you do not have to do anything. So here we have undone the anatomy. We see we have seen that intra-abdominal esophagus length is appropriate, approximately 3 centimeter is inside, and after this we now generally use a braided suture to close the hiatus, and instead of a ethibond, it is giving good results, and it's a continuous suture, and it itself forms a lot of adhesions. Because it was a very large hiatus, we placed a mesh, but now there is some evidence that you can use a biosynthetic mesh in these. We do not use tackles to fix this mesh. We generally use suture because there has been complications with the tackles, including the pericardium and heart injury. In this, because we could see we just did an anterior fundoplication, and because patient main symptom were dysphagia. So this is the other video. In this, patient was operated in some other center, and patient had persistent dysphagia for 3 weeks, 4 weeks. Patient lost approximately 7 kg of her weight, and then came to us, was attempted by balloon dilatation twice there, but there was no response. So here this was a tight wrap. You'll just see the CT scan. In this, this is a 3-dimensional CT scan. We got it done. You will see this CT scan act as a GPS for us, like in map, and it guides us where we have to operate and what is the finding which will we have. So here you could see there is a esophageal narrowing and proximal dilatation of the esophagus. This we also got a 3D image done through the software, and here we can see the tight wrap which is there, and because of which patient was having persistent dysphagia. So then we did a diagnostic laparoscopy. The port technique is same. With the help of Nathasan, we are retracting it. Here, because it was very early, 4 weeks only, there were more adhesions formation formation was there. There are a lot of methods are there to divide this wrap which is there. Either you can use sharp dissection as we are using here, you can see the sutures which are there, or you can use a stapler also, make a tunnel between the esophagus and stomach and fire a stapler. So here we have made a tunnel and between these esophagus and the stomach, and we fired a stapler so that it's safe. Here after this you have to, as we told, we have to restore the normal anatomy. So here we are dissecting the wrap, the left lip of the wrap and trying to dissect this, and after this we are dissecting the right crura and trying to make a window between the esophagus and the crura so that we are clear of the anatomy. Here you would see the sutures which have been taken between the diaphragm and the wrap. So by slowly and patiently with the sharp dissection without the use of energy source, we were able to create windows here and we were able to undo the total wrap which was there. So here this is the right sided window which has been created, and now we are dissecting the right lip of the fundus wrap which is there. Here we could see some stomach was little bit not good, and we thought of firing a stapler instead of suturing. And after this we did an endoscopy. It is very important to do a check endoscopy because tight hiatus closure can also be the cause of this. So if a scope is going easily, it means it is not because of the hiatus closure. So it is very important, if it's a difficult case, you should do an intraop endoscopy, identify the G junction, and it helps also sometime in identifying the gastric or esophageal injury. And after completion of fundoplication, you can again check whether anatomically you have done it at the right place or not. So if there is lot of tension, you might have to do a relaxing incision to so that you relax the incision, give a relaxing incision 3 centimeter right to the right of 3 centimeter to the right crura, and then suture it, or you can place a mesh if required. So short esophagus, you might have to divide the vagus. Sometime you should do good mediastinal dissection till the inferior pulmonary vein. If it is not possible, divide the anterior vagus nerve, it also helps. Or you might have to do a Colles gastroplasty, which is possible laparoscopically if you are not able to have a minimum 3 centimeter of intra-abdominal esophagus. Nowadays biosynthetic meshes are coming up, and mesh is being less favored because it's all a mobile structure. Because of mesh there can be erosions and there can be foreign body reaction and lot of adhesion formation can be there. And some role of conversion to bypass if you are doing a bariatric procedure, or if patient is having a lot of absent motility, you might have to do a Roux-en-Y, or if there is Barrett's esophagus which is severe Barrett's, you might have to do a esophageal resection, or total loss of motility is there. Thank you. It's a teamwork. Without the team we cannot do anything. Our endoscopist, the surgeon, the camera person, everyone are important. With them only you will be able to do, and a good endovision is also very important. Thank you.
Any question from the audience, please? If no, thank you, Dr. Tarun Mittal, for the very wonderful presentation.